My name is Pratiksha and today I will be presenting a neuro case which I have recently seen in the clinic. So the patient ID, my patient is 78 years old female, date of birth 11/12/1946 female. She was presented in the clinic by herself and she is a reliable historian. She came in the clinic with the chief complaint of progressive memory loss, difficulty walking and tremors. So for the HPI, the patient is a 78 years old female who presented to the clinic with progressive memory loss, tremor and difficulty walking, worsening over the past 3 months. She reported frequent forgetfulness, particularly with recent events and difficulty recognizing the familiar faces. Her family also noted about mood swings and episodes of occasional confusion. The patient experienced the hand tremors, particularly when at rest, swing the episodes of confusion. The hand tremors improve with purposeful movements. Additionally, she reported difficulty maintaining her balance and having a frequent fall in the past 3 months. The patient denies any recent changes in vision, headaches, or any seizures. For the medical history, she was diagnosed with Parkinson 5 years ago. She also have a history of hypertension, hyperlipidemia, osteoarthritis, and diabetes mellitus type 2 controlled by metformin. And for the surgical history, she had her hip replacement done 3 years ago and a cataract surgery 5 years ago. For the allergies, she is allergic to penicillin. It gives her rash, and with sulfur drugs she get hives. Current medication list: she's taking carbidopa levodopa 25/100 3 times a daily. She's taking metformin 500 mg twice a day, lisinopril 10 mg daily for her hypertension, atorvastatin 20 mg daily for her high cholesterol, and then she's taking Tylenol 500 mg as needed PRN for her headache and fever. For the family history, her mother, she has Alzheimer's disease, is still alive and is 92. Her dad passed away with a stroke at the age of 80. And then there is no family history of Parkinson's disease. For the social history, she lives with her spouse in an assisted living facility. On the same facility, both husband and wife lives together. For her occupational history, she's a retired school teacher. She denies drinking alcohol, tobacco, or doing any illicit drug use. For her exercise habits, she is fearful of doing any physical activity because she had multiple fall in the past past couple months, like 3 months. So she's not doing any exercise at this point. For the review of system, for general, she reported of losing 5 pounds over 3 months. Even though her appetite is normal. For a neurological, she reports of worsening tremor, memory loss, confusion. No report of recent seizure and syncope. For the cardiovascular, she denies of having chest pain, palpitation, or leg swelling. For respiratory, denies shortness of breath, cough or wheezing. For GI, denies nausea, vomiting, or any change in bowel habits like diarrhea or constipation. For genitourinary, no dysuria or urinary incontinence. For musculoskeletal, she reports frequent fall. She reports of having stiffness in her joints and hips. For psychiatric or mental health, she reports of having increased anxiety and mood swing, no depression or suicidal ideas. For the objective, upon taking her vital signs, her blood pressure was 138/86. Her heart rate was 78, her respiration rate was 18, her temperature was 98.6, and her SpO2 was 96 on room air. On physical examination, for general, she is like a thin woman. She appears frail, but she was cooperative to care. For neurological, upon mental status exam, she's alert but kind of like disoriented to time, short-term memory loss or memory deficit noted. For the cranial nerve 2, all the cranial nerve intact except the mild difficulty with articulation or hypophonia. For the motor, tremors noted in her both hands at rest, more pronounced in the right hand, mild or rigidity in upper extremity, bradykinesia present, a muscle strength 4 by 5 in all extremities. For the reflexes, she has a normal 2+ in all her extremities. No clonus or Babinski reflex present. For the gait, she has a shuffling gait with stoop posture. She has a poor balanced, unable to perform the tandem walking. She was not able to perform the tandem walking. For the sensory, no, not any sensory deficit noted. For the musculoskeletal, a mild joint swelling was noted on both bilateral knees, full range of motion with mild discomfort, but other than the mild discomfort, she was able to perform the full range of motion. For cardiovascular, regular rhythm, no murmur. For respiratory, auscultation bilaterally cleared, no wheezing. For the skin, no dry region or rashes. For the assessment or the differential diagnosis, the differential diagnosis can be Alzheimer's disease, dementia with Lewy bodies, or a vascular dementia. And for the final diagnosis, is a Parkinson's disease. Even though she was diagnosed 5 years ago, it can be just the progressive, or the stage 3 with progressive tremor, bradykinesia, and cognitive decline. Her Parkinson's disease is just getting into a peak or in a different stage. For the plan or medication, we'll still continue carbidopa, levodopa for motor symptoms. We can increase the dose of the medication of carbidopa, levodopa if tremor keeps worsening. We can use our rivastigmine 1.5 mg twice a day for cognitive decline and hallucination. And for mood stabilization and insomnia at night, we can start her on trazodone 25 mg. We can also refer her for some physical therapy so she can get some exercise to improve her balance. That will help her to prevent from falls. We can refer her for some occupational therapy that will work on her home safety and intervention that will minimize from risk of fall. And then cognitive behavior therapy. We can refer her to neuropsycho and cognitive and behavior to manage anxiety and mood changes. And as she lives in the assisted living, all these referral we can do in home, kind of home health, so they can go over there in the assisted living. In that case, the patient does not, my patient does not have to travel, which makes it a little more easier, and the patient was agreeable for this. For the follow-up, we can schedule her for a follow-up in another 4 weeks to evaluate the effectiveness of the physical therapy, medication adjustment, and to monitor any other neurological or cognitive symptoms. And if the symptoms got worsened, we can consider referring her to the neurologist. And for the patient education, we can educate the patient to monitor for the symptoms getting worsening, worse memory loss, hallucination, or any mobility issues. Emphasize patient or getting caregiver support for the need of routine follow-up visit or ongoing care, and using the fall mat and aerial device like a walking device such as cane or walker in order to prevent from the fall being happening. Thank you.